Welcome to MD Newsline, Dr. Kaiser. Thank you so much for taking the time to join us. Can you please introduce yourself to our audience?
Sure. Yeah, I'm Martin Kaiser. I'm a consultant hemato-oncologist at the Royal Marsden Hospital in London, and I'm also a professor of hematology at the Institute of Cancer Research, also in London.
Mm. So you gave a presentation here at EHA. Can you tell me a little bit about what you discussed and what the focus of your work has been?
Sure. Yeah, my focus is actually a bone marrow cancer called multiple myeloma. It's a relatively uncommon cancer, but actually it's common enough for most people to know someone, with the disease. Multiple myeloma is quite an aggressive, or can be quite an aggressive cancer, but it is very different from person to person. It's a disease that we found over the years can have very different levels of aggressiveness, and I have focused on high risk myeloma, so the most aggressive form of this disease, because naturally it causes the biggest unmet need and the biggest problem for patients and physicians alike.
Mm. So what makes a myeloma fall into the category of being high risk?
So it has been for a long time actually very difficult to discriminate or to really diagnose patients with high risk myeloma correctly, because you need really advanced genetic tools to identify it correctly. And only recently have the diagnostic tools really been shaping up so that we can use them more in a day-to-day practice. An important step forward is that very recently, during this meeting, actually, a new guideline has been published about using more advanced genetic tools to identify high-risk myeloma. But there is still even more improvement where we see new data coming out, and that's actually part of what I've been speaking about at this conference, how we can diagnose high-risk myeloma better, but also how we can treat it better, because we now have evidence that we can improve the lives of patients with high-risk myeloma.
Yeah. So tell me a little bit about kind of give me the main beats of your presentation.
So I was really focusing on how we can optimally manage patients with high-risk myeloma. I've already mentioned that diagnosis is a big part of it. And this is something that is, of course, often happening not directly in the doctor's practice. This is actually something where we have to get our tools in the laboratories properly lined up so that a patient gets the full amount of information to make the right decisions. Ideally, it should be a joint decision-making process between the doctor and the patient to understand that we have a different type of disease than most other patients with myeloma, and that different type of disease requires a different type of treatment. The start of treatment, actually, for most patients we have found is now very, very good. So we don't necessarily need to start modifying the treatment for high-risk myeloma patients early. The very first 5 to 6 months of treatment are actually pretty similar for our patients. But what we've learned over time is that high-risk myeloma, many types of myeloma respond to the treatment initially, but the high-risk myeloma patients unfortunately see the disease coming back quite quickly. And that's actually what we've now got a much better handle on through a prospective trial called the Optimum trial that we have run, but there are also other trials that have shown very similar data, like the Concept trial that was run by another group, that really show that the patients stay in a much better, longer remission if we use our drugs better that we have available for this disease. So the trick is that we don't drop the intensity of the treatment after 6 months, but we actually keep it up going. Of course, we need to balance the side effects for the patients as well. But we now have found out, I think, the right balance. Most patients can continue with the treatment for a long time, and we have shown that there is nearly a trebling of the progression-free survival. So patients staying in a remission for nearly 3 times longer than in a comparative group, and we're close to doubling the survival time, actually, of the patient.
What were some of the demographics or profiles of the patient groups that were studied?
It was pretty inclusive. So in the study that was run, the Optimum trial in the UK, we really had a broad coverage of the country. There were 39 hospitals involved. Many of them were community hospitals. So we can really say this is not just, an inner city selected population, but there were many patients from rural areas. There were unfortunately, also in the UK, we have quite a large, population of relatively deprived areas. We have actually ethnic representation of ethnic groups actually in the UK. I think myeloma happens in some populations a bit more commonly, but overall, I think the most The relevant thing is that we have in the past often seen patients from deprived areas not really being represented. And I think in this trial, they have really been able to take part, and we have seen a success of that treatment across the board.
Are there specific genetic markers or chromosomal abnormalities that are now considered maybe definitive indicators of high risk myeloma in the new guidelines at all?
Yeah, there is. It's actually a complex disease, and the genetics are complex equally. So there are mostly large changes of chromosomes.
Mm.
So there are chromosomal translocations. Um, they often co-occur or happen at the same time as well, with parts of the genome being lost or additional gains happening, so chromosomal deletions or gains. And these are the commonest changes that one finds in myeloma. And the worst actually groups are those where several of these co-occur, where they just accumulate these damages over time.
Mm.
Um, there are also, as we call them, point mutations, single nucleotide variants in some very aggressive genes like TP53. But what we also found is that additional tests such as gene expression profiles tell us patients that we can't identify even with the most refined genetic tools. And these patients, it's a similar situation to breast cancer. It's also somewhere where you can find and diagnose patients better when you actually combine different tests. It's the
Mm.
same in myeloma.
And in thinking about this array of tests, what are your thoughts on the disparities in access to advanced genetic testing tools
Mm.
across different healthcare systems? How do we, you know, is there any strategy for this for different resourced systems?
Yeah, it is a challenge, and I mean, I think it will still be a certain inequality or a difference in access that we will see over time, because of course it needs normally countries to some extent invest in their infrastructure, or healthcare systems to invest in their infrastructure to get the diagnostics better. I think it's a big step forward, of course, that we have a better guideline now that actually motivates and really recommends that. I think it makes it easier in systems that have insurance companies to really make the claim or the case for that these patients need to follow the guidelines to full. I think overall, we do see, of course, this happening in many oncological cancers, that the diagnostics are getting more complex, but also actually help us personalize treatment. And that's ultimately what we do if we treat high risk patients differently. We're personalizing treatment in myeloma, and it's an essential part of oncology care. So I think it's something that over time will hopefully only improve.
Hmm. So, what are your thoughts on balancing sustained treatment intensity with quality of life considerations and long term management?
Yeah, it has been, especially when we were setting up this trial, which is now dating back 9 years ago. We were using very new drugs that no one knew actually what they would do to the patient if you give them continuously as a combination treatment for years and years and years. Um, I think it's important always to listen to the patient. Of course, I think all of the long-term care does need a certain form of finding milestones in the treatment where you regroup with a patient and say, is this still also, what you feel is the right thing moving forward? I think we can always express recommendations, and we should do that. With a trial like the optimum trial that we've run now, we can give a very strong recommendation that should be the right treatment. But how patients experience side effects is very different, of course. I think we have hit a good sweet spot with this treatment in that really the majority of patients were definitely able to continue the treatment. And we have measured quality of life that we're analyzing at the moment, but the signal that the patient didn't have to stop treatment is, I think, the strongest one. Nevertheless, when you really use the treatment, it's a very common thing in myeloma that you can improve side effects of treatment quite easily by reducing doses, or let's say giving an extra week of break from treatment, and that often doesn't really impact the outcome. So it's really about listening to the patient and having a good relationship between the doctor and patient to find the right way.
Hmm. When it comes to, hold on a second. So, what specific drug combination or sequencing approaches show promise for high risk patients beyond current standards? Is there anything on the horizon that you're looking at?
Yeah, I think we see a whole raft of new treatments entering the myeloma practice very quickly. Many of them are already being used in later lines of treatment very effectively. So mostly the T cell based treatments These can be CAR T cell treatments or T cell engaging antibodies. There are now bispecific antibodies that are licensed already, but there are already tri-specific antibodies in development. And many of these will have a different effect and a better effect on high risk myeloma than the treatments that we have available at the moment. I think it will really require them coming into early lines of treatment so that more patients can benefit from them, because we do know that in high risk patients, the disease sometimes or often just becomes more resistant with each time it comes back very quickly. So the patients at the moment don't get the full benefit of these new treatments. But that's the normal way how they are developed. We can't really jump massively ahead here. It's already in the making that we're setting up a lot of trials now with these drugs in first line treatment. And I think the outlook for many high risk patients will change fundamentally through that. Having said that, we already see the benefit of that with the patients, for example, that are relapsing at the moment from the Optimum trial. We have already extended their progression time so long that they are benefiting now from trials that use, for example, these T cell treatments in second line. And we see many of these patients going into excellent remissions in second line. It's something that we haven't seen before. I think there's a real hope that we can improve the outcome of many, many lives of patients with high risk myeloma.
Mm. And are there any kind of eligibility criteria for these intensive treatment protocols that we can apply to real world practice?
Yeah, I think this is one of the advantages of how the Optimum trial was run, in that it already included a lot of community hospitals, a lot of sites that are not offering treatment that is just impractical or unrealistic for many people that are treated in the community. Many of the treatments that are given in that trial can even be delivered out of hospital. We have in the UK an increasing system whereby patients can get medications shipped at home. They need to be seen regularly, of course, in their hematology practice, but they can apply the treatments sometimes per subcutaneous injection themselves at home if they're trained up. And of course, there need to be the right safety protocols in place. But if that is the case, then actually these treatments are really deliverable in a standard setting with many patients. I think what is always with myeloma a challenge is that it's a disease of patients that are normally older than 50 years. So of course we have patients that are either having comorbidities and reasons why they cannot have some intensive treatment. And to be fair, it should always be a joint decision making. Some patients, if they are really at an advanced age, they might also say, well, that's not my priority. I don't want to be on treatment that late in life. I think that that's actually, of course, a lot of individualization of care that we do anyway.
Mm.
But outside of that, I would say generally patients that can tolerate treatment can definitely tolerate the treatment that has been developed in that trial.
So, um, you mentioned some of these treatments being able to be administered at home, and that some of these are quite prolonged treatments. What are some strategies do you think would help patients maintain adherence to prolonged treatment schedules?
Yeah, I think especially for high risk myeloma, I would say on the personalization in care myeloma is the knowledge that you have high risk myeloma. It's such an important bit. It's the communication. It's actually having access to the diagnostics, and actually now us having really reliable data to say, well, this is actually something that we can change. If you adhere to treatment, your outcome will be better. I think a lot of it is about that. Outside of that, I think it is mostly a very good doctor-patient relationship, also care team relationship with nurses, to be vigilant about side effects, because many side effects can, through changes in the treatment that sometimes can be minor, it can be an extra week break, they can really be addressed. It's rare that we have a patient who can just simply not tolerate treatment at all.
Mm.
And it's better to talk about it. That's the most important thing. Talk about what the challenges are. And if need be, sometimes one has no other chance, but often the treatment can be just changed slightly so that it's tolerated much better.
Um, how do we monitor? What's the monitoring cadence for monitoring and managing the cumulative toxicity for
Mm.
extended therapy durations?
So the monitoring for myeloma normally is, especially for patients that are on active treatment, to come back to the hematology practice every month for a blood test. We have a very good blood marker for the disease that tells us, especially with patients in a remission, whether they are still in remission. It's actually quite reliable. In larger intervals, we do scans as well, and that's an active area. As it has probably come across throughout the interview, I'm very keen on diagnostics and better access to diagnostics. Myeloma had a big gap in terms of good types of scans for the disease, because the disease sits in the bone marrow that has been hidden to radiating, ionizing X-rays effectively. But new MRI technology, particularly this whole body MRI technology, with diffusion weighting, they suddenly let us see millimeter size lesions in the bone marrow before they cause any trouble. So I think it's the combination of the blood test on a regular basis and interval scans whenever there is a suspicion of that something might not be going right that keeps nowadays patients really, really safe.
Mm. What are some of the unresolved questions about high-risk myeloma biology that you feel are most critical to address through ongoing research?
I think high-risk myeloma, the main challenge is that it develops resistance so quickly. It's nearly to the point that so far the really effective treatment has been the first line treatment. After that, it's been very difficult to get hold or a handle on the disease. I think that underlying this is, of course, that there is a genomic instability. So we do know that genome gets more and more destroyed effectively over time. If there was a way to understand what the processes are that are driving this, to at least freeze it in the moment, that would be really preferable for patients. There is also a new approach in that one of the chromosomal translocations that is associated with high-risk disease now has a specific inhibitor in development. There are early phase trials running towards its the T414 translocation and MMSET inhibitors. But it is still early days to know whether these type of more mechanistic approaches will really help us get the patients into a more prolonged remission, or maybe even revert the nature of this disease entirely. The other aspect is really the new T-cell based treatments. We do definitely see now some patients with high-risk disease that were really resistant to everything else that we had, staying in a remission for many years whilst on the T-cell based treatment. So it will be important to understand what are the characteristics of these patients, because it could be that we might be reverting their high-risk disease already with the right immunological treatments.
Mm. How might emerging technology like minimal residual disease monitoring integrate with genetic risk stratification?
Minimal residual disease monitoring has become a really valuable tool in myeloma now that we also have the treatments that make minimal residual disease negative, so not detectable anymore in many patients. We definitely get the reassurance in patients that their disease is in an optimal response state. And what I think many groups are currently working on very actively is to find out whether some of these patients then could maybe have treatment holidays based on undetectable minimal residual disease. That is really, of course, the biggest challenge that we have in myeloma at the moment, that patients that are on continuous treatment. Now, for some types of disease like high-risk disease, we do know that it's highly, highly beneficial. But by understanding and using diagnostics better, we understand better who has standard risk disease as well. And these are really the target groups in the future. The better we can diagnose that, the more we can advise patients as well to that it is safe to have a treatment holiday.
Mm.
And we can use MRD and minimal residual disease testing as an important part of that.
Mhm. The thought of epigenetics has been swinging around my head this entire time. When we think about the development of things like resistance very quickly, I'm wondering if in your work you saw any subgroups or any sort of characteristics of patients that were more likely to develop resistance very quickly, or if there was anything that was correlated with the speed of resistance development at all.
Hmm. I think we have definitely seen in that patients whose disease has very disturbed genomes already. Like mostly we see that by the accumulation of these chromosomal changes. Um, they seem to have such unstable genomes that they also find resistance pathways much quicker than others. It's of course a relatively crude measure, but actually, to be fair, it is quite reliable. The moment that you find,
Mm.
for example, three high risk genomic aberrations co occurring, the disease is very aggressive and it will find a resistance pathway to the current treatments that we have actually quite quickly. In terms of epigenetic factors, they are present as well in myeloma. I think at the moment their role in day to day diagnostics is still less clear than in other diseases. I think we will definitely learn more about this in the coming years as the study of epigenetic is getting much better with technologies such as long range sequencing, for example.
Mm. And speaking of technology, have you considered at all the use of things like artificial intelligence and machine learning to maybe analyze some of the data from your work and even past clinical work? Because some of the conversations that I've heard is, really around machine learning being used to analyze past clinical trials to see if there are some insights that we can pick up on, and then things like that. So has that conversation come up, or what are your thoughts on that?
I think it's an important and emerging field as to how we can use artificial intelligence to analyze data that we have, and especially combine different levels of data more clearly. But I think the uncertainties that are the biggest is at the moment, how can you make decisions based on that really? And where does a human have to review the data still? Where will it be really reliable enough so that, there is no hallucination in a system somewhere? I think what I work very closely with is colleagues in imaging, and of course in because we're so research active in the use of whole body MRI in myeloma. My radiology colleagues, of course, are involved in their day to day research in tools that in the future should hopefully help radiologists diagnose myeloma, for example, on a whole body MRI scan much quicker. I think at the moment there is more than several thousand images when you do a whole body MRI that a radiologist needs to manually flip through. Effectively, that's, their brains have been over time just getting so used to it, they can do that in an astounding time. But to get there, you need many, many years of training, of course. And I think in image recognition, we might see, one of the biggest, advances over the coming years, really, in how humans can be supported by pattern recognition tools. And then I think from there, we will see next steps, hopefully, over the years after.
Mhm. What are the main points in your talk that you hope to see applied soonest in day-to-day practice?
I think the message, of course, in that we do need to, and patients with myeloma do deserve more diagnostics, is now getting louder. And I'm very glad that I can present, the new genomic classification for high-risk disease. It's such a community effort that will really strengthen the case for all patients. I do think that the data that we have generated with an academic trial like the Optimum trial in better treatment is really striking. It is different from country to country as to how much people will be able to access this type of treatment, but it's been intentionally designed so that it is actually all only using licensed drugs. So I think in some communities, I hope this can kick off a advocacy process where patients and physicians can jointly convince healthcare systems to really make personalized treatment for high risk patients accessible.
Mm, that's great. Thank you so much for joining us on MD Newsline. It's been a pleasure talking to you.
Thank you very much.